Catherine Howell. I'm a neurologist and epileptologist at the Royal Children's Hospital in Melbourne and a clinician researcher at the Murdoch Children's Research Institute, also in Melbourne. I am the lead investigator on an international natural history study. It's great to talk to you today about the phenotypes or a set of clinical symptoms associated with each different subtype of SCN2A related disorders. So the SCN2A gene codes for one of the sodium channel proteins in excitatory neurons. Now, this channel is a major determinant of how excitable the nerve cells are and whether and when they fire an electrical signal to communicate with other nerves. SCN2A related disorders are one of the most common causes of neurodevelopmental disorders. And certainly they're one of the most phenotypically complex. There are numerous distinct phenotypes reported, and these are distinguished by the presence or absence of epilepsy, the age of seizure onset, the response to anti-seizure medications which act by blocking sodium channel blockers, act by blocking sodium channels, and I'll refer to them as sodium channel blockers, and the severity of outcomes. So the initial SCN2A related phenotype described was benign familial neonatal infantile seizures, now referred to as self-limited neonatal infantile seizures, which had treatment responsive seizures which remit by the end of infancy and have normal development. And subsequently, more severe epilepsies were reported, as were individuals with intellectual disability or autism without epilepsy. These more severe epilepsies are referred to as developmental and epileptic encephalopathies. And when we drill down on these, though, we found that these were not just one group phenotypically. So there were phenotypes with onset in the neonatal or early infantile period, including a very severe phenotype with refractory seizures and severe developmental outcomes, and a more intermediate group in which there are some symptoms beyond infancy, whether developmental, seizure, or episodic ataxia. These and the Bifness benign phenotype are united by having focal seizures at onset and a favourable response to sodium channel blocking drugs. Later seizure onset groups were also identified, including one with seizures arising later in infancy, usually with epileptic spasms at onset, and seizure exacerbation rather than improvement with sodium channel blockers. And seizure onset at age 3 months seemed to be the distinguishing point for early and late DEE phenotypes. From now, I'll refer to these groups as the early seizure onset phenotypes encompassing Bifness and early onset DEEs, and the later seizure onset phenotypes encompassing the mid-infancy onset and childhood onset phenotypes. So what's the explanation for this phenotypic variability? How do we know that the different phenotypes are truly distinct? So that is that pathogenic variants in the one gene, SCN2A, cause a number of different disorders. So the answers to this are coming from laboratory studies of the biophysical profiles of mutant channels from individuals with the different clinical phenotypes. So the first thing to note here is that the early onset phenotype in pink is associated with a gain of channel function and increased neuronal firing compared to the wild type non-mutant channel in black. Each of these peaks reflects an action potential or an electrical signal from the cell. And you can see there are a lot more in this mutant channel that causes an early onset phenotype compared with the wild type channel. So it's not surprising that in this gain of function, excessive channel function phenotype, that sodium channel blockers result in some benefit to seizure frequency as these drugs bring the overactive channel back closer to an expected level of firing. So the second thing to note is that the variants causing the mid-infancy onset phenotype reduce rather than increased neuronal firing, seen best on this panel on the right, comparing the blue to the black wild type. So this confirms it as having a different pathophysiology to the neonatal phenotypes. It causes a loss of function rather than a gain of function. And this tallies with the different response to sodium channel blocking anti-seizure medicines. If you block an already underactive channel, you will exacerbate the problem. So to summarise the early seizure onset phenotypes, which have very marked variation in severity, are due to gain of function of the sodium channel, and those with later seizure onset phenotypes, and also, which I haven't shown, the intellectual disability or autism without epilepsy phenotypes are due to loss of function of the channel. So another way of representing the phenotypes is to differentiate them by age of seizure onset, which is on the y-axis, and on the x-axis, and developmental level on the y-axis. The pink and red boxes refer to the gain of function phenotypes, and the blue boxes to the loss of function phenotypes, and the darker colours represent increasingly severe phenotypes. I'm going to take you through each of these phenotypes using data from the literature as well as insights from our natural history study. Beginning with the gain of function phenotypes, you'll notice I've added one additional phenotype here to what I mentioned before, and that is that there are some unaffected individuals. So we see sometimes within families who have, in who there are individuals with a relatively benign phenotype, that there may be some individuals who carry the gene variant and have never actually had a seizure nor any other neurologic symptoms. So beginning with the benign phenotype, there may be a family history, as I mentioned, for example, the earliest described families with biffness. Seizure onset is most commonly in the first few months of life, but actually can be as late as 23 months of age. The seizures are focal. The frequency of the seizures is very variable. Some people have a few seizures only, and some have periods of having multiple daily seizures. The EEG might show some epileptiform discharges, but the background or the expected rhythms there are actually relatively normal. Individuals are usually neurobehaviorally normal babies, that is that they feed, have relatively normal tone, and are relatively appropriately interactive in between their seizures, although they may be sedated depending on the anti-seizure medicines that they have received. Seizures are typically treatment responsive, although not always. Some are preferentially sodium channel blocker responsive, so they may receive non-sodium channel blocking medicines, and these might not stop the seizures, but once they're given a sodium channel blocking drug, seizures typically resolve. In this phenotype, the seizures remit, usually by 12 months of age, but sometimes a bit later. Coming to the other end of the spectrum, the really severe phenotype. Here, there's usually no family history. Seizure onset is before 3 months of age. Most have onset in the first week of life. Again, the seizures are focal. There are usually multiple different types of focal seizures in the one individual. Seizures are typically extremely frequent, multiple daily or even multiple hourly. And the interictal EEG is usually markedly abnormal. So particularly in contrast to the benign phenotype, most individuals have abnormal background activity. So that is the expected age-appropriate rhythms are not present. And the EEG, the ictal EEG, when we record seizures, typically confirms the clinical impression that they are focal seizures. The constellation of seizure and EEG features sometimes fits one of the known severe infant epilepsy syndromes, including Ohtahara syndrome or early epilepsy of infancy with migrating focal seizures, although some don't fit neatly into one of these boxes. Most commonly at onset, the neurologic examination and general behaviour of individuals is not what is expected for age. Typically, individuals are sleepy. They may have abnormal tone. They may not feed particularly well. And some also have abnormal movements that are not seizures. For example, excessive startle and other movement disorders. Initial brain imaging is usually normal. In this phenotype, individuals are typically highly resistant to non-sodium channel blocking drugs. In addition, most are actually responsive to sodium channel blocking drugs. So that is, sodium channel blockers will reduce or sometimes stop the seizures. So which sodium channel blockers? The initial reports of benefit were with phenytoin, sometimes requiring very high doses and actual high drug levels, which high drug levels, or actually any drug level of phenytoin, is quite difficult to maintain in an infant. We often see marked fluctuations and then obviously fluctuations in seizure frequency. Now, it was likely that we saw this benefit with phenytoin because it is one of the drugs used as intravenous loads, and you would, with a load, get up to a high level. And typically what we'd see is each time a load was given, seizures would improve. And after this pattern was recognised in these individuals, they'd often be put on regular oral phenytoin. We've since found that other sodium channel blocking drugs can also improve seizures. It's not clear whether one drug, phenytoin, or one of the others might be more effective, but certainly some individuals are reported to have benefit with other sodium channel blocking drugs, including carbamazepine, oxcarbazepine, and lacosamide. How much benefit do we actually see? Well, typically seizure frequency is markedly reduced, and some will have periods of seizure freedom. Now, this benefit often allows children to be discharged from hospital because previously they were having multiple hourly seizures. However, it's not a miracle drug. Most continue to have some ongoing seizures, whether ongoing seizures every day at a lower level or periods of seizure freedom interspersed with seizure exacerbations, which often correlate with the drug levels in the blood. Importantly, and unfortunately, we don't usually see a significant developmental acceleration with seizure control here. And in addition, we sometimes see a trade-off between seizure control improving, and emergence or exacerbation of a movement disorder or exacerbation of tone abnormalities, and sometimes also changes in alertness. Infants with this phenotype typically have ongoing focal seizures. As I mentioned, sometimes there will be exacerbations back to multiple hourly seizures with low drug levels, and sometimes also with illness. A proportion of these infants may have other seizure types, including infantile spasms or other types of generalised seizures, such as tonic or myoclonic seizures. And sometimes these types of seizures, particularly the tonic or myoclonic, can have a reflex component. So sometimes they can be triggered, for example, by a sudden noise or other unexpected stimulus. Some individuals show some improvement in seizure frequency after about age 2 years. Development is typically very severely or profoundly delayed. And there are multiple factors that can impair development, including seizures, drugs, general irritability, which can be marked, very poor sleep, movement disorders, which can in particular interfere with voluntary motor functions, and also the underlying channelopathy. And we know the underlying changes in neuronal firing in and of themselves perturb the ability for normal development to occur. In some individuals, there's quite a variability between the level of function in different domains of development. So parents will sometimes report, and we can objectively observe that receptive language and cognition is sometimes better than the level of expressive language, or at least verbal expressive language. Some children have non-verbal ways of communicating, such as communication devices. And also motor function is often quite severely impaired. Some children with this phenotype have a need for enteral feeding, whether via nasogastric or nasojejunal tube, or a gastrostomy or jejunostomy. In addition to the seizure and developmental abnormalities, there are a host of other symptoms that can be observed, and really SCN2A related severe early onset phenotype is a very polysymptomatic condition, and these additional symptoms are commonly under-recognised and are a really significant cause of morbidity. In fact, from some work from our natural history study, we've shown that in about half of individuals, their parents report that one of these additional symptoms is actually the biggest problem that they see for their children at the current time, compared with seizures or developmental problems. So these problems can include irritability, including infants crying many hours a day. Poor sleep is common. In the early infant period, sometimes this is hypersomnia, sleeping too much, but often later insomnia can be a problem. Movement disorders are variably present and sometimes can be severe. Children with dystonia in particular can have very significant functional limitations. Abnormal tone is common. Gastrointestinal symptoms can be really severe, including gastroparesis, or essentially almost to a degree of gut failure. Similarly, urinary retention is, I think, more common than we previously had recognised. Unfortunately, these symptoms seem to not benefit from sodium channel blocking drugs. At least we've not recognised that to be of benefit. Unfortunately, there don't seem to be particular pharmacologic treatments that are relatively better than others for each of these symptoms, and our advice usually is similar to when these symptoms are present in children with other neurologic disorders. This is clearly an area that needs significant improvement, and which we hope will be addressed by some of the novel therapies that are in the pipeline. In the severe phenotype, we do see early death in some. In a recent study we've done and soon to submit with recurrent SCN2A variants, we've seen in those with severe early onset phenotypes that just under a quarter of those were deceased. Now, we're increasingly seeing that there are children with early onset phenotypes where the severity is in between that of the benign and severe phenotypes. These children may or may not have a family history of SCN2A related disorders. Often the initial presenting phenotype is quite similar to the severe phenotype, again with focal seizures, although sometimes these can have a later onset, including out as far as 6 months of age, which goes against the previous thoughts that the 3-month age of onset before or after was a distinguishing factor for gain or loss of function. Most individuals with early onset phenotypes have onset before 3 months, but not 100% of the time. Those with intermediate phenotypes can actually have severe epileptic syndromes at onset, such as epilepsy of infancy with migrating focal seizures, again, typically non-responsive or resistant to non-sodium channel blocking drugs. They may have complete seizure control, though, with sodium channel blocking drugs, including with drugs other than phenytoin. Seizures may remit or become less pharmacoresistant during infancy or early childhood. Now, importantly, there was a study a few years ago which looked at early onset DEEs, which actually combined the severe and intermediate phenotypes and showed that a reasonable proportion had good seizure control at the time of report. And so in many children, the time of the report in the literature, they were beyond the infant period and in childhood. Actually, if we tease this apart for those with a more severe versus intermediate phenotype, we actually found that most with a severe phenotype had ongoing seizures, and most with a more intermediate severity phenotype had either a remission or significant reduction in seizures beyond infancy. So the overall levels of severity of the condition does seem to correlate with the likelihood of seizures being an ongoing, very severe problem. In addition, some children have a remission of seizures at the end of infancy, but a later recurrence in the primary school years. And this may be on the spectrum of epilepsies considered to be idiopathic focal epilepsies at the more severe end, approximating the epilepsy syndrome of electrical status epilepticus in sleep. Now, these epilepsy syndromes are again an age-limited phenomenon, which typically remit by the secondary school age years, but they can be quite severe during that time frame. At presentation, the interictal EEG in children with an intermediate phenotype is quite variable. Overall, we have the impression it may be less abnormal than in the severe phenotype, but this hasn't yet been well characterised. Development is quite variable. Some individuals have normal development, but can be severe as moderately impaired development. Typically, these individuals are ambulant, they can walk, but they may have significant impairments in language and communication domains. I should probably just pause here to make a point about how we've defined the intermediate phenotypes. Obviously, I've made the point that this is between the benign and severe phenotypes. But really, we're in the intermediate phenotype, we're referring to individuals who have some symptoms beyond the infant period. Now, that may be developmental problems, it may be ongoing seizures, or it may be the presence of episodic ataxia, so periods of times when balance is markedly impaired, interspersed with relatively normal balance. Now, some of those individuals with ongoing seizures or with episodic ataxia actually have normal development. So the intermediate phenotype, as we've defined it here, is actually has a relatively broad spectrum of severity in and of itself. We've grouped it together for convenience and to avoid having many different subgroups here. So many individuals with this phenotype have tone abnormalities, most commonly hypotonia or low tone. A proportion have episodic ataxia. Occasionally, you can actually have an episodic ataxia phenotype without having had seizures during infancy, but the majority have had seizures during infancy. There are some studies of episodic ataxia in SCN2A related conditions, which showed that sometimes acetazolamide or Diamox can improve the symptoms, and that some individuals were treated with sodium channel blocking drugs, but the response to these was often somewhat disappointing. Gastrointestinal symptoms, again, are common, including significant constipation at times. And again, it can sometimes have a more significant impact on quality of life than is perhaps sort of recognised by the medical fraternity as being a part of this condition. Typically, though, these are not as severe as in the severe phenotype. So in amongst the gain of function phenotypes, We consider these to be a spectrum of severity with a lot of overlapping clinical features. However, even though they're a spectrum, and as I mentioned, the intermediate phenotype in particular is quite broad, we actually find it convenient to sort of group these as distinct phenotypes, even though we recognise it's actually a spectrum. So there's very marked variation in severity here. How do we prognosticate early in the piece? It's really important, both for clinical prognosis with current treatments, as well as for understanding who might benefit most from novel treatments, to be able to determine early in the piece who is likely to have a poor outcome with existing treatments. And this is not necessarily as easy as I might have portrayed, as not every infant who presents severely will actually have a severe outcome. So trying to determine early markers of outcome severity is something that's being actively worked on. What might help us predict this? So one thing that people have postulated is potentially the genotype, so the specific gene mutation. This does actually not correlate well in many cases with outcome severity. About 40% of recurrent early onset variants, so variants that have been reported in more than one individual, had variation in the severity of the phenotype, including some variants in which individuals with very severe phenotypes and benign phenotypes are reported. What about the biophysical profile, the laboratory characterisation of how overactive the channels are? This is, again, the subject of some ongoing work, and I would say watch this space. Then we've got clinical features, and the answer is that probably early clinical features will help us predict the severity of outcome. So here is some initial data from studying the clinical features of individuals with recurrent SCN2A variants, and this is taken from the literature and from our SCN2A natural history study. So each of these figures show for different clinical features. So for example, on the top line, the SCN2A variant, whether it's de novo or inherited. On the next line down, the age of seizure onset, etc. So figures show for the different clinical features, the proportion who had normal, mild to moderately impaired or severely impaired developmental outcomes, in green being normal development, orange the mild to moderately impaired, and red being severely impaired development. So it showed that there is a high proportion with severe outcomes if the presenting syndrome, well, epilepsy syndrome, was Ohtahara syndrome or epilepsy of infancy with migrating focal seizures, or if seizures were refractory to treatment or responsive only to phenytoin, but not other sodium channel blocking drugs, or if there was an evolution of seizure types to epileptic spasms. Conversely, there was a high proportion of normal outcomes if seizure control was obtained within 3 months of seizure onset, or if seizure control was obtained without needing a sodium channel blocking drug. We also showed that for some previously identified favourable prognostic features, so that includes inherited variants and seizure onset greater than 3 months of age, the outcomes were mostly, but not universally normal. So these are not 100% accurate in their predictions, although are in most cases associated with favourable outcomes. And finally, de novo variants. So this is up on the top line. De novo meaning a new change in the child not present in the parent, so non-inherited variants. These are generally or have generally previously been considered to be likely associated with more severe phenotypes. But here we show that more than 20% of individuals with de novo variants had a normal outcome. So de novo variant doesn't always bode poorly. Now, while these data are useful and they suggest that clinical features might predict severity of outcome, they also have some limitations. So the data was predominantly taken from the literature, so not all the data points were available for all individuals. And also there are some potentially relevant data points at the time of initial presentation that weren't looked at, and so the subject of some future study. Some of the features I mention here are features mentioned that are present during infancy, but not necessarily present within a month or so of onset. So moving on now to the loss of function phenotypes. So we have a mid-infancy seizure onset phenotype, a childhood onset phenotype, and a phenotype where there are no seizures present. In the mid-infancy epilepsy onset phenotype, there is usually no family history. And in fact, for this phenotype, there are no unaffected individuals reported, like there are in some of the gain of function phenotypes. The seizures are not the first manifestation in most individuals. Most prior to seizure onset have developmental delay, and some may have additional features including irritability, vomiting, failure to thrive, or a movement disorder. Now, these are variably present, and where they are present, they're of variable severity. There are reports of individuals in whom these were very severe and sometimes resulting in months spent in hospital, even prior to seizure onset. Epilepsy typically begins between 3 and 18 months of age, but most in the first year of life, at a median of about 8 months. The initial seizures most commonly are actually generalised seizure types, so typically they're infantile spasms, but sometimes they can be tonic seizures. Interictal EEG is typically markedly abnormal, most commonly the chaotic EEG pattern known as hypsarrhythmia. And the epileptic syndrome often meets the criteria for West syndrome, although again, sometimes individuals have a constellation of features that doesn't fit one of the well-recognised epilepsy syndromes. Epilepsy is unfortunately treatment resistant in most, but not all individuals. It's not uncommon to see that some have an initial treatment response, for example, to steroids, although seizures actually recur in most of these individuals, for example, during the weaning of steroids or shortly after. And most seizures continue into childhood, again, mainly as generalised seizure types, sometimes more than one will be present. And sometimes the epilepsy syndrome as a move into childhood can be consistent with Lennox-Gastaut syndrome. I mentioned that not everybody has ongoing seizures. A small proportion have seizures stop. And where seizures cease, there seem to be roughly between age of 18 months and 6 years in those individuals. Some of these individuals have a very clear exacerbation with sodium channel blockers, but some have also have had no exacerbation or even benefit reported, and we really don't understand this very well. Where there's an exacerbation, it's commonly with extremely frequent seizures, essentially status epilepticus, but usually as very frequent brief seizures, often tonic seizures, and often putting the child in hospital. Sometimes this can be very soon after the first dose of a sodium channel blocking drug. There is no single anti-epileptic drug that's consistently reported to be of benefit. Most children end up on combinations of non-sodium channel blocking drugs. There are a number of children reported to have had benefit with many of these different drugs, but also with the ketogenic diet as well. So as I mentioned, development is often delayed prior to seizure onset. Some individuals will have a developmental regression at the time of seizure onset, and most have a severe developmental outcome in the longer term. Autism spectrum disorders may be present, but are not universally. Some individuals have other features. Again, we should consider the loss of function SCN2A phenotypes to be very polysymptomatic. That is, almost all individuals have symptoms other than developmental impairments and epilepsy. Movement disorders, particularly choreoathetosis, can be present in some individuals. This is very well reported for a couple of the different variants, including R853Q, but is present in some individuals with other variants with a mid-infancy epilepsy onset phenotype. Tone is typically abnormal. Microcephaly or a small head may be seen in some. Gastrointestinal symptoms, again, can be very prominent and severe. And other episodic symptoms are sometimes present, including episodes of very profound agitation, which sometimes occur at times when seizures are relatively well controlled. The actual nature of these episodes is really not clear, nor is it clear what might help terminate these episodes. They may last for some days. Moving on to the childhood onset phenotypes, again, usually no family history. Seizure onset is in or after the second year of life, actually quite commonly in the pre or primary school age years, and onset up to 17 years of age is reported. There are quite variable electroclinical phenotypes or epilepsy syndromes amongst this. And the reasons for people having one or another is not really clear at this point, but some children, particularly those with onset in that toddler or preschool ages, have generalised epilepsies with seizure types including myoclonic, tonic-clonic or absent seizures. Sometimes this is consistent with the epilepsy syndrome of epilepsy with myoclonic atonic seizures. Some have focal epilepsy, so with focal seizures. And again, some are consistent with the spectrum of idiopathic focal epilepsies, including electrical status in sleep, like I mentioned in some of the early onset intermediate severity phenotypes. Children with these phenotypes have quite variable treatment response. Often the epilepsies are treatment resistant for some time before ultimately remitting, which actually is a feature of many of the idiopathic epilepsy syndromes that are present in childhood. And in children with SCN2A related conditions can behave similarly to what we see where the cause of these epilepsy syndromes is something else. Benefits most frequently reported with non-sodium channel blocking drugs. So for example, sodium valproate, benzodiazepines and levetiracetam. A proportion of individuals have had exacerbation with sodium channel blockers reported, but occasional individuals have reported benefit. We don't really clearly understand again why that is. There is a recent laboratory paper which actually reported that in cellular models, so not a single cell neuronal model like I mentioned before, but actually sort of more network models, that actually in these apparently loss of function phenotypes, at a bigger level, sometimes there can actually be increased firing. And that's really not that well understood, but it's been postulated to be that there may be compensatory impacts of other channels which overall essentially overcompensate and increase the firing. But that in and of itself doesn't, wouldn't explain why there's such variability in symptoms unless that were only present in a proportion of individuals. Sorry, why there's such variability in treatment response, I mean. Overall, we actually don't know what proportion of individuals would have worsening versus benefit with sodium channel blocking drugs, as most individuals with these epilepsy phenotypes, if the underlying cause were not known, wouldn't actually be given treatment with sodium channel blocking drugs. They're not the drugs preferentially used for these types of epilepsy. So actually this remains a question that we don't really know the answer to. Another thing I would mention is that there should be some degree of caution with episodes of variable different types of symptoms that are actually not seizures but might be mistaken for seizures that sometimes crop up in children with these conditions. Maybe not necessarily at the start of the epilepsy, but sometimes if there's new symptoms or episodes that crop up, it bears sort of scrutinisation as to whether these new symptoms are seizures or not. And so sometimes these can include like on non-epileptic staring spells, episodes of really sometimes very profound unresponsiveness, which can be thought to be absent seizures, but are actually non-epileptic and reflect, I guess, a sort of really profound sort of, I guess people refer to it as daydreaming, although that's probably not quite the most accurate way of referring to it. But these may not be seizures. This is an important thing to recognise because if the episodes are actually, if some of the episodes are not seizures, then escalating seizure treatment to try and deal with those is actually not the best thing to be doing. Development may be normal or abnormal prior to seizure onset. What we see not uncommonly is that development is initially normal in the first few months or even the first year of life, then becomes abnormal, and it may become abnormal prior to seizure onset. Sometimes development can plateau or regress, sometimes seeing a plateau, particularly of language development in the second year of life, can be a feature. But a plateau or regression may not be present in these early times, but may occur at seizure onset. Again, this is not universal. Developmental outcomes are quite variable. Oftentimes we find relative strength in gross motor skills, and in oral intake, it's uncommon for children with this phenotype not to be able to feed orally. There are typically relative weaknesses in communication, but a range of abilities, which ranges from non-verbal through to being able to speak in sentences. And many individuals are able to follow some simple commands. Amongst the children in our natural history study, most have a score on a communication function scale of 4 or 5. Now, what that equates to is having communication abilities whereby what a child is trying to communicate is not always apparent to a familiar individual. So particularly where a parent is not always able to tell what their child is trying to communicate to them. Autism spectrum disorder diagnoses are common. Hypotonia is common. Gastrointestinal symptoms and poor sleep are common. So you'll notice that the additional symptoms I've mentioned have actually been extremely similar across the different phenotypes. So SCN2A related conditions typically encompass all of the same symptoms, just present in different patterns and different ages. Some children don't have seizures, but just have an intellectual disability and or an autism spectrum disorder. Now, many of the features in the developmental trajectory are very similar, if not exactly the same, as those with the childhood onset epilepsy phenotype. So development may be normal initially, although sometimes it is abnormal from birth. There may be a period of developmental regression, although many don't have this. And again, the developmental outcomes are variable. And I could repeat what I'd said for the previous phenotype because it is actually very similar. Again, many, but not all, have a diagnosis of autism, and those that don't often do have some traits or features of autism spectrum disorder symptoms, although not the full hand. One of the things that seems common amongst those that do or even don't have an autism spectrum diagnosis is very significant sensory sensitivities often. Sometimes these can be extremely severe, including some children being so sensitive to having their hands or feet touching any kind of surface, that it can markedly impact on their ability to advance in their gross motor skills, such as stand or walk. And some children actually acquire these skills really quite late, at which the sensory sensitivity seemed to be something that has markedly impacted on their ability to obtain these milestones. Again, this is not a universal feature, and in many children, they're not that extreme, but they can be. Again, the other clinical symptoms are similar to the other phenotypes I've mentioned. One thing that is of significant concern to families of children with this phenotype is whether or not their child will develop seizures in time. As, for example, you can see that many of those with the childhood onset epilepsy phenotype would have actually fit this ID-ASD without epilepsy phenotype prior to starting to have seizures. It's estimated that about 1/3 whose initial presentation is with the phenotype that does not have epilepsy will develop epilepsy sometime in childhood. Can we predict who will and who will not to help give families a greater likelihood of whether or not their child will? At this point, no. And we have some more work to do to see whether or not there are features that might distinguish those who do and those that do not develop epilepsy. So we come back to the different loss of function phenotypes. The question again arises as to whether these are a spectrum of severity, like what we saw in the gain of function phenotypes, or whether they're actually distinct disorders. At this point, we don't know completely, although it may be that they are distinct in that the mid-infancy phenotype may be different to the other two phenotypes. So at this point, clinical trials are on the horizon, and we have a number of unanswered questions that we really need to answer prior to clinical trials. So we need to know how to select the right trial candidates, and how do we determine whether a novel treatment is effective. Now, this latter question is going to be informed by our natural history study, which is in progress. But determining the biophysical impact of the condition is one of the major things we need to do to be able to select appropriate trial candidates. This is because the different treatments are likely going to be required for gain of function compared with loss of function phenotypes, as giving the wrong one could have terrible consequences. If you have a treatment to bring a gain of function back to a more normal level of firing, you give that to a child with a loss of function phenotype and reduce their already abnormally low firing further. This could be catastrophic. But actually knowing gain of function versus loss of function is also important for current clinical practice, including regarding whether to preferentially use or avoid sodium channel blockers. So how do we know if something is gain or loss of function, if a variant is gain or loss of function? Well, one way is studying the biophysical profile in the laboratory, as I've mentioned and shown you before. But not all variants have been characterised, and it actually is quite a bit of work to characterise a variant. And is not necessarily quick. We can use clinical features to some degree to determine this. So gain of function causing the early onset phenotypes, and loss of function the later onset and ID-ASD without epilepsy phenotypes. I mentioned it's previously been thought that before or after age 3 months for seizure onset was the cutoff for distinguishing gain versus loss of function, but I've also told you that this doesn't always work. There are some exceptions, so particularly amongst the gain of function phenotypes, those with benign or intermediate severity phenotypes may actually have seizure onset after age 3 months. So adding in some additional criteria can help distinguish this. But again, I would caution at this point, we still need to review these criteria in more individuals to confirm that they do always hold true. And as far as a trial situation goes, we really would still want biophysical confirmation of gain versus loss of function to make sure we were as confident as possible that we were giving the right treatment to the right individual. So the additional criteria over and above age that I'm referring to is to try and capture those individuals with gain of function phenotypes who have later seizure onset. And so the features present there would be sometimes seizures can have onset between 3 or 24 months, so in the first 2 years of life. But we only see a gain of function phenotypes in those individuals if pre-seizure, so prior to seizure onset, development was normal and epileptic spasms are not present. So gain of function before 3 months or after 3 months before 2 years, but only if pre-seizure development was normal and epileptic spasms or infantile spasms are not. So I'll leave this summary slide up just while I wrap up here. So SCN2A phenotypic groups are increasingly well defined, but we've still got some work to do. We know from studying recurrent variants and from laboratory studies of whether a variant results in gain or loss of function, that the genetic change or biophysical impact can predict which phenotypic group someone will be in. So for example, earlier onset versus later onset, but particularly amongst the early onset or gain of function phenotypes, the variant, genetic variant does not predict the phenotypic severity. We need better measures to be able to work out likely phenotypic severity early in the piece, including determining whether early clinical features might predict outcomes. Evolution over time, especially in a quantitative sense, is still being worked on as part of natural history studies, and this is important to provide data that we need both to select appropriate candidates for clinical trials and choose which outcome measures might be appropriate to use in trials to determine whether outcomes in individuals are improved by novel therapies over what would be expected if those therapies were not available or not used. So I mentioned we were conducting a natural history study. We now have over 90 participants from 17 countries. Thank you very much to everyone who's participated. We really appreciate your time and effort here. Recruitment is ongoing, and we're just about to submit the first paper that includes data from this study for publication. And in addition to the data we've already collected, we have some additional quantitative data collection commencing. So that includes some validated developmental assessments, and it includes things like seizure diaries. If you are interested in participating, you can contact us on that email at the bottom of the screen, and we'll provide you with some more information to tell you what participation actually involves. If you'd like some more information about SCN2A related phenotypes, here are a couple of resources that summarise them. And finally, a big thanks to everyone listed here who's been involved in our SCN2A related work, including our research team, many collaborators around the world, the funding we've received from the Australian government and from pharma companies Praxis and Rogcon, and also from a number of patient-focused foundations and groups, including SCN2A Australia, who are putting on this conference. Most importantly, a very big thank you to the children and their families affected by SCN2A related disorders, who have provided their time and effort to help us in our work. Thank you.